Okay, everybody. Well, welcome to tonight's presentation. Tonight, I'm going to be reviewing the diseases of the kidney, some of its epidemiology, some of the new treatments that we have for kidney disease, how we diagnose kidney disease, and also some brief comments about the research that's going on that's quite exciting. So this slide just shows a breakdown of the known causes of kidney disease, and it really reflects data both in the United States and worldwide. As you can see from the slide, about 44% of all patients with kidney disease have the disease because of diabetes. So as I'll talk about a little later on, diabetes is not just a disease of sugar. It's a disease that affects multiple organs in the body, and it's actually a major cause of why patients are admitted to the hospital or why patients see doctors in general, because it affects so many different organs. And it does so because it actually destroys blood vessels over time. Now, not in all patients. There's certain patients that are predisposed to having the blood vessel abnormalities, and so what that results in is poor blood flow to different organs, depending on the organ that's involved, that then leads to the disease of that particular organ. And the kidney is one of the organs that's affected in diabetes. Another major cause is high blood pressure. This is a complicated category because it's a question medically of what the chicken and what the egg are. Many nephrologists will say that high blood pressure leads to kidney disease. But that's really overly simplistic. If you look at the data, there are many people that have different types of reasons for their high blood pressure that don't have any kidney involvement at all. And so it's very likely, although it hasn't been proven definitively, that many people that have high blood pressure with kidney disease got the high blood pressure because of the kidney disease. So the kidney disease came first, and then that led to abnormalities that result in high blood pressure, rather than the converse, that people got the high blood pressure first, and that then led to kidney disease. So it's a confusing category in that sense, even though most renal trainees in the country and most nephrologists will say, oh yes, of course, high blood pressure damages the kidney. But if you look at the data, it's not that clear at all. And there are, of course, many exceptions to that. Now, high blood pressure can lead definitively to remodeling of the heart and abnormal functioning of the heart. And it appears that it also can lead to abnormalities in the brain, where people are more likely to get strokes. But as far as whether it can damage the kidney, it's not as clear. And then we have smaller categories. The 7% at the bottom there refers to what we call glomerular diseases. I'll talk about the glomerulus. That's the filter in the kidney. We have about 1 million in each kidney, and there are diseases that specifically affect the filters. Now, diabetes also affects the filters in addition to affecting the blood vessels coming into the kidney. So it's sort of, you get a double hit with diabetes. Then there's genetic diseases. You might have heard of polycystic kidney disease, and I'll show examples of that. That's an entity where you get large fluid-filled cysts coming out of the kidney, and the kidney starts looking like a bunch of grapes rather than this smooth organ that it typically is. And then there's a whole grab bag of other diseases that we call other, some of which I'll talk about tonight. Now, if you look at deaths per year in the United States, it's widely unrecognized what a major player kidney disease is. People would be very surprised to find out that deaths from kidney disease are about 2.5 times breast cancer. I mean, from all the press that breast cancer gets, the marches, et cetera, kidney disease gets a lot less PR. And there are multiple sociologic reasons for that, which I won't get into now. But as far as all the cancers, there's only one cancer that causes more deaths than kidney disease, and that's lung cancer. So every year in the United States, there's about 100,000 people dying from kidney disease, and you multiply these by 1,000 to get the number. And again, it's per year in the US. Lung cancer is about 135,000 a year. Breast cancer is about 43,000. And it exceeds prostate cancer significantly. Colorectal cancer, it's about double. So this would be surprising to a lot of people. I might say that the deaths from kidney disease, and I'll talk about it because we have various treatments, 2 types of dialysis and transplant. The patients don't die of kidney disease. They die of cardiac disease. So if they have associated heart problems, that's what causes the death. They're not dying of kidney failure because we have methodologies for replacing that function. Now, just some more data on the prevalence and the cost of kidney disease. Worldwide, there's about 8.5 billion people on the earth, and 850 million worldwide have had some form of kidney damage. Now, these aren't patients on dialysis. They have less severe kidney disease, so they don't require what we call renal replacement therapy. But they still have kidney abnormalities that can lead to different clinical phenomenology and also need to be followed by their doctors. And a disproportionate number are African Americans or Hispanics. In the US, there's about 40 million people that have kidney disease, many of whom don't even know it because you don't have symptoms. You just go to the doctor and they tell you, oh, your kidney blood test was abnormal. The major test is called creatinine. We'll talk about that. So people go and get their blood taken and the doctor goes, oh, your creatinine is abnormal. And they go, what does that mean? Well, that's your kidney function, but they feel completely normal. That's the typical scenario. And in the US right now, there's about 650,000 people who are on dialysis. It's not an exact number, but it's pretty close. And that number has remained pretty constant and maybe even falling a little bit. It used to be going up quite significantly every year, but we're getting better at treating patients before they need to go on dialysis, preventing their kidney function from getting worse and worse and worse every year until they require it. We're slowing down that rate of worsening with some newer drugs that are coming on the horizon. And it's not widely known that Medicare spent about $114 billion last year on kidney disease. Now, remember, Medicare doesn't typically cover diseases. It's an age-dependent insurance. But in the 1970s, a bunch of nephrologists went to Congress and said, we have this new treatment called dialysis, and it would be unethical if the US government did not cover the treatment. So we should be, as a country, paying for kidney care. And so the Congress agreed ultimately to cover kidney care under the Medicare program. And that cost has gone up year after year after year as the number of dialysis patients has increased. And they also cover part of the transplant. And last year it was a huge number. And just to give you a rough idea, the Medicare budget is about $800 and something billion a year. It's almost $1 trillion a year. So you can see that a significant fraction of that total expense is kidney care, which is why in the last 3 or 4 years, kidney disease has come on the radar in the federal government, particularly when Trump in 2019 created an executive order to significantly improve the care of kidney patients. There was a whole day spent on the White House. All the big shots in the kidney organizations were there, patients, etc. But that executive order pushed a number of things. One, to try to get patients out of dialysis clinics and to look after themselves more at home, either with peritoneal dialysis or with home hemodialysis. Secondly, to significantly increase the number of transplants being done every year. Right now, we have 100,000 people in the United States waiting for a kidney transplant, many of whom will die waiting for that transplant on dialysis, especially the ones that are significantly older. And then a third part of that executive order was to create an artificial kidney. And we'll talk a little bit about that. In addition, the US government is spending more on kidney innovation. There's a prize that was created called the Kidney X Prize that our group has won a few times for the work it's doing on the artificial kidney. And it's a public-private partnership between the ASN and Health and Human Services to try to fund different types of innovation in the care of kidney patients. Now, as far as the population dynamics, as I said, there's about 650,000 patients who are on dialysis currently, and about 100,000 new patients come onto dialysis every year, and about 100,000 patients who are on dialysis die every year. So the number stays about the same. Now, the kidneys, for those of you that aren't familiar, are small little organs that are sort of on the back part of your body, in the upper part of the abdomen, and they weigh very little, about 1/3 of a pound each. But they're very important organs, as you'll see, because they don't just get rid of water. They actually control the entire chemistry of your blood. So when we look at a more granular level of what's inside a kidney, there are functioning units that we call the nephron. And I'll talk about that in a minute. And there's about 1 million of these in each kidney, so they're very small. You need a very powerful microscope to see them. And they consist of a part called the glomerulus. The glomerulus you can think of as a filter, like the filter, let's say, in your bathtub or any filter that you're aware of. Blood comes into it, and what comes out of it is filtered blood. And by filtered, we mean that the cells in the blood, the red cells, the white cells, and the platelets can't get through the filter. They just return to the body, and you get like a yellow liquid coming through that you might have seen when you get a cut, that kind of thing. It's called plasma. It's blood without cells. That gets into the first part of what we call the nephron. And the nephron is a tube that I'm showing here with many different parts. And each of these parts does something different. And they're made up of different cells, all of which have different functions also. So some of these cells transport sugar, some of them transport salt, some of them transport water, calcium, phosphorus, magnesium. They all do different things. And once they have done what they're supposed to do, at the end comes out what we call urine. Now, this just shows one. You can think of it like a tree-like structure with all these things joining up to each other. All the 1 million in each kidney join up until the final urine comes out of the kidney. Now, that's what comes out here. But then it goes into this tube called the ureter. Each kidney has a ureter, and the ureter then goes into your bladder. Now, the kidneys are always working. So why is it you only have to urinate 3 or 4 times a day? Why don't you urinate all the time? The kidneys don't stop working. They're constantly working 24/7 throughout your whole life. They don't take a break like the brain. They don't know what a vacation is. They don't know what I have to go to sleep means. And they don't know what I'm tired means. They're working all the time. But we don't urinate all the time. And that's because the bladder will fill up to about 1/3 of a liter before it sends a signal to your brain that your brain interprets as, I have to pee, I have to go to the bathroom. So until the bladder fills up to that level, you don't get the sensation that you have to urinate. It's about 1/3 of a liter. If you know what a 2-liter Coke bottle looks like, you can picture about a sixth of that volume. The bladder fills up. And then if it's functioning normally, it sends a signal to the brain, and then when your brain says, okay, I'm going to the bathroom, the brain sends signals down to the bladder to contract and push the urine out. And then it just starts filling up again. It's constantly filling until again it fills up to about 1/3 of a liter, and then you go again. So what does the kidney do? Well, it's very important for getting rid of salt. And we'll talk about why. Here's just a little cartoon saying the patrons at table 5 want to know how you managed to get such a wonderful taste in your salt-free soup. So salt is very important, and this cartoon sort of alludes to the fact that people often say, well, I don't take any salt. You know, I don't use a lot of salt in my food. But you have to realize there's salt in food, even if you don't add it. And so you really have to be careful if you have issues with your kidney getting rid of salt to know what the salt content of the food you're eating is. And it's always on the package, so you can always check it. And we'll talk about why that's important. So the kidney doesn't just get rid of salt, it also gets rid of water. Here's just a cartoon saying your tests reveal that you are retaining fluids. If your kidney doesn't work properly, you can't get rid of the water you drink. Now remember, the kidney is keeping your blood chemistry constant because your blood chemistry is always changing when you eat. When you eat, it's not just simply putting something into your body. That all the chemicals in the food you eat are broken down in the intestine, and then they're absorbed into the bloodstream. And it significantly, every time you eat, changes a ton of chemicals in your blood. And if nothing else happened after that, you wouldn't live very long. The kidney recognizes the change in all the things you're eating that affect the blood chemistry and makes sure that it gets rid of them comparable to what you ate. So roughly the kidney is recognizing what you ate and getting rid of it, thereby keeping the chemistry of the blood relatively the same from day to day. The kidney also gets rid of potassium. So here's a cartoon saying, and this dish is totally potassium free. Well, there's nothing on the dish. And what this is implying is potassium is in a lot of foods. So it's pretty hard to have a potassium-free diet. It's in fruits, it's in meat, it's in fish, it's everywhere. And so, but there are patients who we have to restrict their potassium intake because their blood potassium goes too high, usually because the kidney is unable to get rid of the potassium normally. There are many diseases affecting the kidney's ability to get rid of potassium. Bananas is a common source of potassium, but as I say, every fruit, oranges, watermelon, bananas, they all have potassium, and meat and fish. The kidney also gets rid of what we call nitrogen, and nitrogen comes from meat. Nitrogen is what is turned into, is part of protein. And that's what becomes part of our muscles. So our muscles are all protein, and they need a certain amount of nitrogen to maintain their size. And also, obviously, if you're working out, you're going to have more protein and more nitrogen going into your muscles because you're bulking up. But the kidney regulates the amount of nitrogen that leaves the body because the body only needs a certain amount. And if you're eating too much protein, generating too much nitrogen molecules in your body, the kidney will recognize that and get rid of it. And the substance that it gets rid of nitrogen with sounds like urine. It's called urea. You might have heard of urea. It's a chemical compound, and the nitrogen that the kidney is getting rid of, the kidney doesn't get rid of free nitrogen. It gets rid of nitrogen in the form of urea based on whether you're taking in too much nitrogen or not. The kidney also controls your blood pressure, and it does so by modulating how much salt and water it gets rid of. Now, it's not well known, but 45% of Americans 18 years of age and older have high blood pressure. So almost half of the US population has a blood pressure that's too high. Now, 4 or 5 years ago, the American Society of Cardiology and other entities lowered the levels of what is called high blood pressure. Now, remember, with blood pressure, there's two numbers, and there's a reason for that. The high number, the 130 in this example at the bottom, is the pressure when your heart beats. So when your heart sends a beat, the pressure goes high. But after the beat, you still have a pressure. It's just not the peak pressure. Your pressure doesn't go to zero when the heart in between a beat. Remember, let's say you're beating once a second. Well, in between those beats, you still have some pressure. It's not the highest because the heart's didn't just send a pulse out. So we have a pressure at the pulse when the heart actually creates a beat. And then we have a pressure after the beat, between beats, which is lower. So that's the low number. That's why we have two numbers. Most people don't understand that. And we look at both numbers. We want to, if when we're treating patients, make sure both numbers are lower. There's a large literature on blood pressure, and people question, well, is it the high number that leads to problems like strokes and remodeling of the heart? Is it the low number? And there's data out there for different clinical entities where one might be more important than the other, but we don't usually get that granular. We try to treat both. And usually they track together. It would be unusual, although we see patients that have, let's say, the upper number is 190 and the lower number is 70 or 80. That would be unusual. Usually both are high. The other thing that the lay public loves to talk about is I have a low blood pressure. That's a misnomer. We don't really discuss that in medicine unless someone has a very low blood pressure, like 70/40 or 80/50. That's low. But a pressure of 98/65 or 70 is completely fine, and we don't call that low blood pressure. But it's very common for patients that come in the clinic and go, you know, doctor, my pressure's high, but my wife has a low blood pressure. And you say, what is it? Oh, it's 100/60 or something, that kind of thing. That's completely fine and normal. If the pressure gets too low, you can get lightheaded because the brain recognizes that the pressure has dropped. And if it gets very low, the brain will actually make you become less conscious and you'll fall to the floor. And that makes sense because when you fall to the floor, the heart doesn't have to pump against gravity and your pressure comes back to normal. So that kind of reflex where if the pressure drops too low and you faint to the floor and your pressure comes back and you wake up, only works on the Earth where we have a gravitational field. It's not going to do very much if you're in the space station and weightless. So it's because we have gravity that you're able to fall to the floor and wake up as your pressure comes back to normal. So we often ask patients who are on blood pressure pills, do you feel lightheaded? Especially people who are 75 or 80 or 85, who are more sensitive to blood pressure pills. We don't want them to drop too low because if their pressure drops too low, that can lead to other problems. And there's a lot of people 75 and 80 in this country who are over-medicated with blood pressure pills. And that can lead to problems in and of itself. So we always, in people that age, opt on the safer side and we cut the dose back and we let them have, you know, higher pressures than we would in someone who's 18 years of age, who can tolerate things better. The blood pressure, by the way, also varies throughout the day. It's like the weather. It's not constant, or like the stock market. Every time you look, you get another number. So when someone says my blood pressure is 140/90, our first question is when? Our second question is, were you lying, sitting, or standing? Because just doing that changes the blood pressure. So if the doctor is good, he'll get a good history. He'll find out how the patient took the blood pressure, lying, sitting, or standing, because you get a different number in all those three situations, and find out when the pressure was taken, because the pressure is different in the morning, afternoon, at night, the middle of the night. We have what's called a diurnal variation, which means it fluctuates predictably in a 24-hour cycle. So blood pressure tends to start going up around 4 or 5 in the morning in a normal person and peaks late afternoon and then starts falling in the evening again. But there are people that have different patterns. When we're treating someone, we always want to make sure that we're catching the peaks and the highs, but not dropping the normal too low. So we have to do that by changing when we give the pill. Some people we give the pill to in the morning, some we give in the afternoon, some we give in the evening, because the pill only lasts for a certain period of time. And we want to make sure we're catching the high point, but not having the pill lower the normal one, which it can do if it overlaps with the normal period. So it can get a bit tricky. If we don't get a good feel from the patient as to what their blood pressure is throughout the day, we will get a machine that will automatically give us the pressures over a period of a week. There's a cuff that inflates automatically and records the pressures, and the patient doesn't have to do it. But typically, we tell everybody to get a blood pressure cuff, and the Omron blood pressure cuffs are great. They're about $60. You get them on Amazon. And we tell everybody, measure your pressure and then bring your records into the clinic. And we tell them also, we do not decide on blood pressure treatment based on a number we get in the clinic because it's always high. It's called white coat syndrome. When patients come into a clinic, they're afraid, they're nervous, they're anxious, and their pressures are always higher. And we don't want to treat pressures that were just high momentarily because the patient was upset. So we go by what the patient got at home, and we ask them to either keep an Excel spreadsheet or an accurate log of those pressures in a book. And then we look at them, we look at the time, the magnitude of the abnormality, if there is, and then make a decision on treatment after that. And there's many different types of blood pressure pills that have effects different ways. Some blood pressure pills make your kidney get rid of more salt and water. That's one way of lowering the pressure. Other blood pressure pills make your blood vessels dilate, which means they have a bigger diameter, and that lowers the pressure also because you have the same blood volume, but now it's in the pipe is now bigger. The pipes are bigger, so the pressure drops. Or we have pills that affect the strength of the heart or the number of beats of the heart. That will also lower the pressure by targeting the heart. And some pills overlap. They have multiple mechanisms of function. Or sometimes we have to use multiple mechanisms because one approach didn't work. And there's a lot of people in this country who are on 2 or 3 different types of blood pressure pills because you just can't get the pressure down with one type. Okay, well, the kidney, in addition to those things, also controls what we call our blood count or our hemoglobin, you might have heard of, or hematocrit. That's an assessment of how many red blood cells that you see here are in your blood. So remember, the blood is like a river, but inside it are cells, red cells, white cells, and platelets. These are the red cells, and this is what determines your hemoglobin, how many red cells you have in the river, in your plasma. If they drop too low, you get what's called anemia. I'm sure you've heard of someone who's anemic. It refers to the number of red blood cells in the blood. And there are many reasons for anemia. That's a whole lecture in and of itself. But the key point from this is that the kidney makes a hormone called erythropoietin that tells the bone marrow is where the red cells are made before they get into the blood, tells the bone marrow how much red cells to make. And we increase the erythropoietin, the bone marrow makes more red cells. Now, you might think that's really strange. What would the kidney have to do with making erythropoietin? Why isn't that hormone somewhere else? And the reason has to do likely that the kidney is sensing the amount of oxygen in your blood too. And these red blood cells carry oxygen to your body. That's how oxygen gets to your entire body. It's not free floating in solution. It's actually bound to the hemoglobin that's in these red blood cells. And that the oxygen is much more efficiently carried to your tissues that way. So the more red blood cells you have, the more oxygen you can carry to your tissues. And so it sort of makes sense that the kidney is sensing the oxygen and then determining how much erythropoietin to make. But be that as it may, people who have damaged kidneys don't make as much erythropoietin and they become anemic. And that's what we were facing until about 25 years ago when Amgen cloned erythropoietin and started being able to make it synthetically. And we call it EPO for short. And that's what kidney patients have gotten since that time. And that's how they became a multi-billion-dollar company. It changed the world. Until then, patients were anemic and we had to give them blood. And the problem with giving them blood was that they developed antibodies that could potentially affect an organ, if a kidney, if they got a transplant. People were always worried that they could reject more because they were creating antibodies against the blood that would react with the transplanted organ. We don't have to face any of that anymore. We just measure patients who are on dialysis or who have severe kidney disease. We measure their hemoglobin. If it's low, we give them erythropoietin. It's given under the skin once a week or once every 2 weeks. Some people are every 3 weeks. Everybody's different depending on their needs. The kidney also is important for making sure that your bones are healthy because it regulates the amount of calcium and phosphorus in your body. The kidney produces a hormone called 1,25 vitamin D. This is not the vitamin D you get in the pharmacy. The vitamin D you get in the pharmacy is not active. The kidney has to turn, that's called 25 vitamin D. The kidney has to turn it into 125 vitamin D. That's the active form. And 125 vitamin D regulates calcium and phosphorus because it goes to your intestine and makes your intestine absorb more calcium and phosphorus from your diet. If you don't have 125 vitamin D, you have very low calcium and phosphorus absorption from the diet, and your bones are going to get weaker. There are other hormones that regulate your bones and calcium and phosphorus. And one of the important ones is called PTH, or parathyroid hormone. The kidney doesn't make parathyroid hormone, but patients with kidney disease have parathyroid hormone abnormalities that we have to treat with different drugs, because if the parathyroid hormone goes too high, which it typically does in patients on dialysis, the parathyroid hormone can affect your bones. So we have to make sure that it doesn't go too high, because we want to make sure that patients on dialysis have healthy bones. We don't want them to get osteoporosis. We don't want them to get microfractures and that kind of thing. But this is something we're always monitoring in all patients. But the bottom line is the kidney determines the health of your bones also. Now, there are diseases that affect the kidney, and I alluded to one of them, diabetes. But kidney, like other organs, can get cancer. Obesity, for some reason, in some patients can affect the kidney. Millions of people get kidney stones. I'll show some of those. There are other inflammatory diseases of the kidney, such as lupus, some of the glomerular diseases we call the GNs, the 7% that I was showing in the first slide. There are genetic diseases of the kidney called polycystic kidney disease. There are viruses that can affect the kidney, such as AIDS or HIV. COVID-19, it's not really talked about, but many of these patients get kidney disease, kidney failure, and I'm monitoring that every day at UCLA. We are tracking all the patients in the hospital that have COVID, and of those, which ones get kidney disease and require dialysis. And so that's a whole new literature in the last 2 years. That virus can directly affect the kidney, and it can cause kidney disease, kidney failure from other reasons that requires dialysis. Often it's a short time, maybe 4, 5, or 6 weeks in the hospital, and then the kidney recovers. But in some patients, they become chronic dialysis patients. The kidney never recovers. There are bacteria that can affect the kidney in addition to viruses, and a whole slew of drugs can affect the kidney. The big ones that we see are the pain pills, ibuprofen, aspirin, Tylenol, no. But these pills called non-steroidal anti-inflammatory agents, people don't recognize it because they take ibuprofen or Motrin all the time for pain. But if you take a lot of these pills, they can destroy the kidneys. And just something to be aware of. Tylenol is much safer as far as kidney disease. If you only take some ibuprofen or Motrin, nothing's going to happen. If you're taking 5, 6, 7, 8 pills every day for months and months and months, you better get your kidney function checked. And then there are other diseases that we call obstructive kidney diseases, where the kidney's fine, there's no disease of the kidney, but what we call the lower urinary tract. So the urine comes into the ureters, as I talked about, then it goes into the bladder. But in men, you have a prostate gland sitting right under the bladder, and the urine goes right through the middle of the prostate gland. And if your prostate becomes too big, it can actually block the outflow, and now everything just backs up. The bladder backs up into the ureters, backs up into the kidneys, and the kidneys can get damaged. And so there are many men, I mean, most men over 60 have a prostate problem. I mean, it'd be very unusual that you don't. And so it's just something to be aware of. Most men after 60 have trouble urinating. They say that they go to the bathroom and then 5 minutes later they have to pee again. The reason is they didn't empty. The bladder can't empty because of the blockage, so they still have some urine left and they have to go again. That's one thing. Plus they notice that the urine stream slows down a lot. It's not like when you're 18 years old, it takes a lot longer for it to come out, again, because of the obstruction. Some people don't empty, and so they're always having urine in their bladder, and that's something else that is assessed. It's called the post-void residual. A normal young male voids and the bladder is empty, but if you have obstruction, you have what's called post-void residual, where you pee, and now we measure, and you still got about 100 cc's of urine in your bladder. Well, that's not good. It means that you have an obstruction. So what you have to do is send the patient to a urologist, and the urologist then will assess it, assess whether the prostate's abnormal. This isn't prostate cancer, it's just generalized growth of the prostate that's very, very, very common. And what he'll do is, it's called a TURP. They stick a device up and they ream out the inside of the prostate to make the opening bigger, allowing the urine to come out. And what happens initially is you're leaking all the time because you can't hold it in. So you have the opposite problem, but eventually it works out. So if you have kidney diseases, the question is, how do you recognize it? So one thing, if you have severe kidney disease, is you'll start getting fluid overload with swelling in the feet that we call edema. That's just because you're not getting rid of your daily water intake. So the water stays in your body, and because of gravity, it collects in your feet. And you notice towards the end of the day, your feet are more swollen. You can't get your socks on, you can't get your shoes on. And then you lie down at night, and without gravity, the feet get less swollen. In the morning, you're fine, because the fluid got absorbed back into your blood. But throughout the next day, you're standing, walking around, the feet swell up slowly throughout the day. That's fluid overload. The other thing they get is nausea and lack of appetite. Not clear why. There probably are chemicals that are not getting, kidneys not getting rid of, that lead your stomach to be upset. So if someone has severe kidney disease and they start saying, I really feel nauseous all the time, I don't have an appetite, we call that uremic. And that's really a sign that they're going to start needing dialysis. You just can't wait anymore. As I say, kidney disease can lead to high blood pressure because you can't get rid of the salt and water. It can lead to what we call electrolyte abnormalities. These are different electrolytes in the blood. These are chemical symbols. Na is sodium, K is potassium, Ca is calcium, Mg is magnesium, P is phosphorus, HCO3 is bicarbonate or baking soda, like the baking soda in your cupboard. Kidney regulates all these, and these blood tests all go abnormal when people start getting kidney disease, and we watch all of them and we correct them as needed. And of course, if they require dialysis returns these concentrations to normal. Patients can be anemic, as I said, because of lack of erythropoietin. Something that's not discussed a lot is patients with kidney disease can get depressed, obviously because of the situation they find themselves in and the life-changing dialysis, which many patients just hate. Others get used to it. It really depends on your personality. And then there are symptoms from the kidney disease that can mask like depression, like you feel sleepy, you don't want to get up, you don't want to see people, you don't want to go to work, these kind of things. You don't want to interact socially, you're angry all the time. These may or may not be depression. They may be from the kidney disease, and you need to have someone assess whether it's depression or not. And there are tests that psychological tests people can do to distinguish real depression from something that looks very much like depression but isn't. There are sleep disturbances in patients who are on dialysis and who have kidney disease. Some of them sleep during the day more, stay up at night. They have sleep abnormalities. Not all of them, but a number of them. Abnormal taste is a very common finding in patients on dialysis. They just find the food is very bland. They just say it doesn't taste like it used to. And there are a number of reasons for that people are discovering. But in general, we don't have a drug yet that can fix that. We just tell the patient, put a ton of spices and salt and things on the food that you wouldn't normally do to make it taste, have a better taste. And people succeed at doing that, or they don't. Some people just give up and they say, that's it, forget it. Others work out a way of making the food taste better if possible. Now, kidney disease is the tip of the iceberg. As I said, patients can have a lot of renal function abnormality, up 50, 60%, and not be diagnosed. So the iceberg is below the surface, and the patients are only typically coming to the doctor when it's very severe. We also don't get referred the patients from the primary care doctors and the other specialists until it's very severe. That's something that's been going on for 30, 40 years. You'll hear hospital systems try to figure out ways of improving the consults to kidney doctors. It's already a 40-year discussion. No one has solved it. And there are many reasons why we don't get the consults. We've tried education, we've tried everything under the sun, and it's still, and even the EMR where it should be it can be more automatic. If the kidney function goes below a certain level, have an automatic consult. These things help, but we're still not seeing all the patients we should be seeing. We're getting them late. And again, when I say kidney function, that's a very general term and might be confusing because I just gave you about 10 different things the kidney does. When we say the kidney function's abnormal, we're specifically only talking about what the filter does, the glomerulus. We're not talking about the rest of the nephron. People can have totally normal filters, but have problems in the cells in the nephron that are transporting, let's say, potassium. We don't call that abnormal kidney function. We don't call that kidney failure. When we say those terms, we're only talking about the filter being abnormal, because this is what determines whether someone goes on dialysis, not the other functions of the nephron or the kidney that I talked about, only whether the filters are fine. So we have a machine called dialysis that I'm sure you all heard of. It was invented in 1942 in occupied Holland, Nazi-occupied Holland, by Kolff, who was working in a small little hospital trying to escape the Germans. And he came up with this technique. It was very, very different than this machine. It used actually sausage casings, which were made of cellophane that he put the blood through, and the technique was very, very different. The blood went into a huge drum, a rotating drum. It didn't flow into the machine automatically. He would collect the blood and then run it through and then have to recollect the blood and infuse it into the patients. At any rate, after the war, he went to the Peter Brent Brigham in Boston, and there they refined the machine and actually started selling these machines in the early 1950s for about $5,000 a piece. And dialysis really took off in the United States, hemodialysis in the 1950s. Patients typically do it 3 times a week for about 3.5 hours at a time, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. They typically come to a clinic. In the United States now, it's all private. It never used to be, but the 2 big players are DaVita and Fresenius. They look after almost, the majority of patients in the U.S. Of the 650, DaVita is looking after probably 200,000, 180 to 200,000. Fresenius is a bit smaller. The rest are smaller dialysis companies. There's only a few private dialysis units left. I mean, in the 1950s and 60s and 70s, they were all owned by nephrologists. That's how nephrologists made their money. They set up a dialysis unit and looked after their patients there. Medicare was paying the bill, and that all changed when they sold their units to these big companies. But hemodialysis can affect people's lives. Here's a cartoon where the stewardess is saying, "I do sympathize with you, sir, but I'm afraid it cannot be viewed as carry-on luggage." So it makes it harder to travel when you're on hemodialysis. Although what patients do is, let's say they're at a DaVita unit, they will ask DaVita to see in another city what units have empty chairs, and they will just arrange ahead of time to be dialyzed in those units. And they just, change their schedule accordingly. Now, I forgot to mention, but when I said it's 3 days, 3.5 hours at a time, don't think that that replaces what the normal kidneys are doing. That is the minimum amount of purification of the blood that's required to keep a human alive. We're only like 10 or 15% of what the normal kidney does. We're not replacing what the kidney does. Even if you went on a hemodialysis machine 24 hours a day for 7 days a week, it still wouldn't be as efficient as a normal kidney. So that evolved the 3 days, 3.5 hours at a time, just because it's really the cheapest way of keeping a patient on dialysis alive. Optimally, we would do patients longer, and there are research programs where people are on longer treatment times. Some of them are doing research looking at patients doing dialysis overnight, every night, where they come to the dialysis unit and sleep there, and they get dialyzed at night, or they do it at home at night, all night, 5 times a week, 6 times a week. Those patients tend to do better medically, just because they're getting more purification of their blood. But typically, that's not what we do on a typical patient. Now, what evolved in the 1970s was another type of dialysis called peritoneal dialysis, where you don't have needles stuck in your arm, there's no blood, but you have a catheter in what's called your peritoneal cavity. This is a little thin cavity under the abdomen, and normally it has no fluid in it, and normally it's very flat. We don't even think about it. But scientists discovered that you can fill it up like a balloon with a lot of fluid. And so what they thought was, okay, if I put the right fluid in, I can have the chemicals from the blood, the toxins from the blood go into this fluid. And then all I have to do is drain this fluid after a certain period of time, and I'll get rid of the impurities that way. So what evolved was to put a 2-liter solution in, usually 2 liters, if you think of a 2-liter Coke bottle, into the peritoneal cavity through the catheter in the abdomen, that's in the abdomen. And you leave it in for a couple hours. It collects all the toxins, and then you drain it and put in fresh solution. So a patient on peritoneal dialysis typically has this solution going in and out 5 times a night, and it sits in the abdomen for 2 hours. So they dialyze for about 10 hours. Sometimes it's a little bit less, but let's just say typically a 2-liter solution in for 2 hours and draining. And in the 1990s, a machine was created that does it for the patients. They don't have to do anything. They just have the bags there, and the machine takes the solution, puts it in, gets rid of it. And so all they have to do in the morning, they have to hook themselves up at night. They have to do it sterilely. They attach the tube from the machine to the catheter in their abdomen. You can see the girl doing that there on the left. That's a cartoon. That's just a picture. She'd normally be ideally wearing a mask and gloves. You have to do it sterilely. You don't want to, because the major thing is you don't want to get that infected. And there's, all our hands, skin have bacteria on them all the time. And so you have to do it sterilely to prevent an infection. And when you unhook yourself in the morning, you have to also be very, very careful. So they hook themselves up once a day at night, and they unhook themselves once a day in the morning. And they just do this every night for the rest of their lives. There are a few patients who do it manually, and they hook themselves up after and remove the catheter after every solution. They do it by themselves. They don't want the machine, which is the way it was done initially in the 1970s and 80s before we had a machine. As far as a transplant, that's the third way we can look after kidney patients, so-called renal replacement therapy. It's a common question. What happens to the other kidneys? The answer is we leave them there, and people have 3 kidneys. We leave them there even though they're not functioning completely normally, because they might have a little bit of function left, and we don't want to lose that. And secondly, they can often still make the hormones. They make the 125 vitamin D, and they make the erythropoietin. So we don't want to lose that. We can give the patient erythropoietin and 125 vitamin D as a drug, but if we don't have to, that's much, much better. So we never take the kidneys out unless there's a very, very, very good medical reason. What about research? Well, if you think about it, the treatment that we just talked about has been around, for 40 to 60 years. Nothing's changed in the kidney space, even though the cost of looking after these patients has gone up and up and up and up year after year. So one approach we're taking is to develop an artificial kidney where we can create a device that will not simulate everything the kidney does, because we'll never be able to do that, but at least replicate the essential functions of the kidney. They will allow patients to have a life independent of dialysis or a kidney transplant. Because remember, although a kidney transplant is great, you still have to go on drugs to prevent the rejection. And these drugs have side effects. They increase your chance of getting certain cancers. If you've had cancer in the past, they can reactivate a cancer. Some of the drugs cause diabetes or pre-diabetes. So there's all sorts of side effects from being on these drugs, even though, you know, it's an amazing procedure. People get off dialysis and return back to their regular lives. So this is one of the things that's being done in the United States now. And this just shows a video of what we're trying to do. I don't think I'll show the whole video just because it gets pretty technical.
The function of a kidney while still fitting within a backpack to enhance the patient's quality of life. While the device consists of many different functional modules, the combination of sensors and smart software allow an easy interface for doctors to view patient data and patients to manage small changes to accommodate their daily activities. The purifying process begins with blood flowing from the patient through a catheter, as shown in red on the top right. It then flows to a peristaltic pump and enters the ultrafiltration module, which is shown as a cylinder on the far left. This module retains proteins, white blood cells, and red blood cells to be returned to the patient's bloodstream through a separate catheter, as shown by the red stream returning out of the top left. Our system uses a unique nanocellulose membrane, which allows for minimal fouling as well as a high flow rate. The module allows smaller substances dissolved in blood, such as glucose, urea, and ions, to pass through as shown as the blue stream leaving the bottom of the ultrafiltration unit. From there, the stream flows through a sensor bank to analyze the patient's initial ion and urea levels to determine the removal amount using the smart software. Next, the stream is pumped into an electrodeionization module, which is shown as the blue flow into the top left rectangular module. The electrodeionization module uses an electrical potential to selectively transport various ions, mainly potassium. The ion-depleted stream is then sent to a level sensor to monitor the flow rate and pumped into the bottom port of the nanofiltration module, which is shown as the second cylinder on the right. The nanofiltration module is used to separate glucose, which needs to be returned to the body, from urea, which needs to be excreted in the urine. The stream with the concentrated glucose is returned to the body through the catheter. The stream with the concentrated urea is shown as the blue flow exiting from the top. From there, it is sent to the activated wafer electrodeionization, or a WEDI module, which is shown as the rectangular unit on the top right. The WEDI module contains multiple wafers that are selective to different ions. This allows for ions to be transported in different amounts depending on changes in the patient's blood chemistry due to alterations in dietary intake. The smart software calculates the amounts of different ions that need to be removed based on input from the sensor bank. The stream with the ions removed is then returned to the patient's bloodstream. A second stream, which contains the concentrated urea and ions for removal, is recycled back to the first electrodeionization module, where it picks up the potassium that needs to be removed. This stream is then pumped through a level sensor to determine the flow rate, and then to the reverse osmosis module, which is shown as the cylinder on the far right. The reverse osmosis module is used to prevent excess water loss in the patient and to concentrate the synthetic urine stream, which contains the urea and ions for removal. The flow comes into the bottom of the unit, and clean water is sent out the top and back to the patient, while the synthetic urine stream is sent out of the bottom for disposal.
I know that's a lot of technical terminology. I wanted to show that not because it's something that anyone can initially understand. It's highly technical, but just to show the complexity of what has to be done to simulate what the kidney does. This is a highly complicated device. We've spent over $3.5 million on the initial prototype, you know, we hope ultimately to have a device that will be initially in the form of a backpack that the patients can keep on a desk or on a night table at night to purify their blood. Ultimately, there'll be an implantable version, hopefully. The difficulty with the implantable version is that if any of the components stop working, it's going to require an operation to swap out a defective part, whereas if it's on the outside the patient, very easy to replace defective components. Okay.
The function.
This device we were pretty proud of was, was called one of the 5 coolest things on the earth by GE in 2020. So that was we were thrilled to for that recognition. So back to diabetes. What does diabetes do to the kidney? So the cartoon says God sent Adam and Eve out of the garden because of the apple. Apples have carbs. Carbs are evil. That's not the problem with the kidney. The problem with the kidney is, as I mentioned, it affects 2 parts of the kidney. The first are the blood vessels coming into the kidney. Not unique to the kidney. As I said, it affects the blood vessels throughout the body. But you look at a nice blood vessel here, and this is one that diabetes has damaged. It's getting narrower. There's plaque and all sorts of material here on the inside. That's going to lead to less blood coming to the organ, which can lead to problems. But the second problem, as I mentioned, is that the filter. This is a picture of one of the filters. This is a glomerulus. You can see this is very nice the way it looks. Look at the diabetic one. It's getting filled with all this stuff, and the filter just stops working over time. And it takes normally about 18 years to go from here to here. So let's say you have someone who's 20 years old who gets type 1 diabetes. 40% of those patients go on to end-stage kidney disease, and it takes about 18 years till this occurs. So it's a very slow, progressive process with every year their kidney function getting worse and worse and worse until it reaches a point where they need dialysis. And that I didn't mention. Let's say your kidney functions 100%. You don't need to go on dialysis till it gets down to about 15%. So you can lose a lot of kidney function and still the kidney can look after your bodily needs. But when it gets down to about 15% of normal, that's when you start feeling nauseous, retaining fluids, blood pressure going up, all the things that happen that until then the kidney was able to still handle. Cancer, like all organs, kidney can get it. And this CAT scan just shows a big mass in the kidney. And this is a cartoon showing the same thing. We have different ways of getting rid of this. Sometimes it's such that the whole kidney has to be taken out. But sometimes, depending on the size and where it is, they can take out just the cancer itself. And another way they're doing it now is radioablation, where they put radio waves into the kidney and actually they heat it up to the point where the tissue just dies. So there are a number of ways of dealing with it. Some patients need chemotherapy, others don't. It's one of the rare tumors. It's not often the kidney gets cancer. Kidney stones, a big problem in the US, 15 million Americans. There's some stones on the right, they look like a stone. And the stone can form anywhere in the kidney. In fact, the kidney itself, the kidney tissue itself can have calcium all throughout here, looks like salt and pepper. That's called nephrocalcinosis. It's not a stone, but the calcium is precipitating in the tissue, throughout the tissue. If it's a stone, it's here where the urine is starting to come out. This is where the urine comes out of the kidney, these things. And it joins up into the ureter, but you can get a stone here, here, or here. If you get a stone here and it blocks the ureter, that is extremely painful. And the pain, they say, is worse than being pregnant. The pain starts in the back where the kidney is and then travels around to the front, right into your groin. And it's excruciating. You're screaming, you need morphine. It's pulsing because the ureter is actually contracting to try to push the stone out. And every time it contracts, it sends out to the nerves. Terrific pain. It's not a lot of people can't tolerate it. They're crying. It's horrible. So you know when you get a kidney stone. If the stone passes through, is small enough, depending on the size, a couple of millimeters, there's no pain. It just comes through. And sometimes, if you're lucky, you'll see it come out into the toilet water. So people that tend to pass a lot of stones, we tell them to take a piece of gauze and pee through the gauze so that they collect the stone for us so that we can analyze it. Because there's different types of calcium stones. Calcium, and it doesn't have to be calcium. It can be, if it is calcium, it's either calcium oxalate or calcium phosphate. And we treat those differently. It doesn't have to be a calcium stone. It can be uric acid. Remember, uric acid is what causes gout. If the uric acid precipitates in a joint, you get gout, an inflamed, painful, usually it's the big toe. But uric acid can also precipitate in the urine, and then the stone is made of uric acid. We treat that differently. So there's different types of stones, and it's very valuable if the patient was fortunate enough to bring it into us so we can analyze it. There's another disease called IgA nephropathy. It's one of the diseases of the filter, the glomerulus. This is actually a blown up of one filter. It looks all green because of what we call an antibody, a fluorescent antibody that we're using to analyze the glomerulus. And it's binding to this other antibody called IgA. I won't get into the technical part, but it's a very common cause of glomerular disease, especially in Southeast Asia. It presents with blood in the urine. And so, because normally, remember, this filter, as I said, is preventing red blood cells from getting into the nephron. They don't go, red blood cells typically don't go through the filter. That's where our urine isn't red. Blood can't get into the red cells can't get into through the filter. But if you damage this, they get through the filter and the red cells are coming up now into the urine. So it's something we look for, whether there's blood in the urine. And this is one of the filters. And you have to look at a lot of these, but this one, a nephrologist or a pathologist can look at and go, that's abnormal. There's just a lot of these cells that shouldn't be there, and they're in a specific location. So IgA nephropathy, very common cause of a glomerular disease in humans. Still don't have a good treatment for it. And it can lead to damage of the filter sufficiently for a patient ultimately to need dialysis. We follow the patients in the clinic, we follow their kidney function and try to keep it, as normal as, not normal, but try to keep it as least impaired as possible to keep them off dialysis. But sometimes it just keeps progressing and progressing, and they start feeling nauseous, they start getting swollen feet, blood pressure goes up, and those are all the clues that they really have to get some form of kidney replacement therapy, either hemodialysis, peritoneal dialysis, or a transplant. The most common cause of red urine is not blood. The most common cause of red urine is someone who ate beets hours before. So every time we see, or a patient tells us my urine was red, we ask them, did you have beets? So many times they say yes. And if they did, we tell them, just wait, the urine will return back to its original color. This is polycystic kidney disease. As I mentioned before, the kidney gets these cysts that look like big grapes. Kidney should never look like this. Fluid-filled, urine-filled cysts. And they get worse and worse and worse, and this can damage the regular kidney tissue, so their kidney function, their filtration ability decreases and decreases. And as I say, it's about 10% of people, I didn't say it before, but about 10% of people on dialysis, if you go to a dialysis unit, 5 to 10%, it's because of this disease. And it's inherited in an autosomal dominant fashion. That means that you only need one parent to have it, and you have a 50% chance of getting it. You don't need both parents. It's not, you don't get the gene from both parents, which we call autosomal recessive, just from mother or father. And we always take a family history. You ask, did your mother or father have kidney disease? No, they died of a heart attack when they were 30. So oftentimes you never find out. But it had to come in most cases from the mother and the father. Sometimes you can get a new mutation in the sperm or the egg. So when you were being created, your parents didn't have the disease, mother or the father. But in the sperm or the egg that created you, either one got a mutation in this gene, you will have the disease. So that's another way you could get it and not have gotten it from your parents. And that's true of any genetic disease. You can get a spontaneous mutation in the sperm and the egg, and you have no family history, no one before you got it. But now you're going to be able to pass it down to your children. So that's another thing that comes up. Let's say you're 60 years old, your doctor says because you tend to not to have a problem until you're 40, 50, 60. Let's say you're 45, your doctor says your kidney function's abnormal. I did some imaging and it looks like you might have a lot of cysts in the kidney. And I think you might have polycystic kidney disease. So since you know you have a 1 in 2 chance of passing this on to your children, your first question obviously is, what about my children? Should they get tested for the genetic mutation? And that's a complicated answer because they may be perfectly fine when they're 18, 19, 20. And their kidneys may look fine because these cysts develop later on in life, not when you're a teenager or in your 20s typically, often. So but the mutation they can get from your DNA. You always have that mutation. You were born with it. So they do the genetic test on the kid. Now they find he has polycystic kidney disease, or he has the mutation. Well, that can affect his insurance. So oftentimes the parents don't want to test the kids. They want them defined as being normal from the insurance side of things until they're forced to, and they get the cysts in the kidney and that kind of thing. So it's a problem with the insurance to do testing that's too early, because now you're going to be defined as someone with a disease, and that affects your insurance possibly. Lupus is another disease of the kidney. Again, another disease that affects the filter. This is a normal filter, just to refresh your mind. This is the abnormal one, filled with cells. It's inflamed like crazy. It's bigger than normal, swollen. It's obviously not going to filter. And so we have to do something, or this young girl is going to end up on dialysis if it gets bad enough. Lupus is a disease where you start attacking your own tissues. And you can get inflammation in multiple tissues, brain, heart, kidney. Her cheeks are red. We call that the butterfly rash. That's because she has a lot of inflammation here, and her blood vessels under the cheeks are dilated, and there's more blood coming to the cheeks, so you can see them. Butterfly rash, typically in young women in their late teens or 20s. Don't usually see this in men. It can also affect their hair. They can lose their hair. They have light sensitivity. Not a good disease to get. High blood pressure I mentioned, because of the kidney not being able to get rid of salt and water. So how do we test for kidney disease? So here's a scanning electron micrograph showing 4 filters. Remember, we have 1 million in each kidney, so I'm only showing a few. But just to make the point that it's that when the filters stop working is what we call kidney failure. Not the rest of the nephron here, the tube part. If this is abnormal, we don't call that kidney failure. It has other names, and it doesn't lead to dialysis. Only problems with the filters. And we have a nice blood test to assess the health of the filters. If your filters are all normal, then this test called creatinine should have a result of about 1. So when you get your blood measured, if your creatinine's 0.9, 1, your glomeruli, your filters are normal. If your creatinine goes from 1 to 2, it seems like a small change, but it means a lot more. It means you've lost half of your filters. In each kidney, you've gone from 1 million down to 500,000. Now, as I said, you can go down to 15% of your filter function before you need dialysis. So you still are okay, but you've got kidney disease, and our goal all the time is to prevent it from going from 1 to 2 to 4 to 6 to 7, where you need dialysis. We call this CKD. You might have heard that term. It means chronic kidney disease. So once your creatinine starts going up, you have what's called CKD, and that means you have filter problems. Our goal all the time, we'll see you every 3 months, every 6 months, every year, is to keep your degree of CKD from getting worse. We have different CKD stages, 1, 2, 3, 4, 5. And they just refer to different severity of the filter problem. If you were 2 and you went to 4, you lost another 50% of your filters, which means you have a quarter of your filters working. You're getting close to 15%. You're now to 25% here. Now, our problem is going from the 1 to 2. Most docs recognize the 4. But going from 1 to 2, a lot of the primary care docs, other subspecialists, they don't refer to us. We should be seeing a patient when it goes from 1 to 1.2. But most of the time, it's totally ignored. And so we don't get a chance to assess the problem. Why are their filters not working? What are we going to do about it? primary care doctor totally ignores it, doesn't even mention to the patient there's an abnormality. Now, some people start at 0.7, let's say. If they go from 0.7 to 1.4, they've also lost half their kidney function. And they're even harder to pick up because the numbers seem so small and low to a regular doctor. So it's a major problem in medicine, the lack of recognition of changes in the creatinine. And it's something that the public needs to be educated about. You need to know what your creatinine is and make sure it doesn't change throughout your life. And then you can be assured that your kidney function, your filtration is normal. You'll never have to worry about dialysis. The other thing we assess, in addition to the blood creatinine, is the urine. And we look for protein in the urine because the normal filter, the normal glomerulus, keeps protein out of the urine. It doesn't get through, just like the red cells don't get through. But with a damaged filter, the protein gets into the urine and we actually measure it. We measure it with this stick here, whose color changes with the amount of protein in the urine. And we can also send the urine to the lab and they'll give us a number of how much protein is in the urine. One clue that you might have protein in your urine is it becomes foamy. Now, it's for sure not the most common cause of foamy urine. The most common cause of foamy urine is in a man who was peeing from too high up, and he makes a lot of bubbles. We get that all the time. Doc, my urine looks foamy. I say, were you peeing from high up? So that is the most common cause. But if it's not that, then protein in the urine can make it foamy. We also test for blood in the urine. As I mentioned, IgA nephropathy presents often with blood in the urine. There are many, many diseases that cause blood in the urine, from the kidneys all the way down to the bladder, and that's something we distinguish. We call it lower urinary tract bleeding. So bladder cancer, problems with the prostate, in the man, problems with the epididymis, all these things can cause bleeding. It has nothing to do with the kidneys, which are way higher up, versus the kidney being the source of blood, where the filters are not keeping the blood from coming out, such as IgA nephropathy, etc. So once we see blood, we then have to diagnose where in the whole system the blood is coming from. Oftentimes, we'll have urine with blood in it, but you won't see red. So the tube that looks on the right here clear, and this is just water, but the tube that looks clear under the microscope could have red blood cells in it. So we don't just look at the urine, we also take a sample and look under the microscope to see whether there's blood in the urine. And that has significance too, because you're only supposed to have a certain number of red blood cells in normal urine. There are a few that leak through normally, but if it's more than that, it's telling you there's something abnormal. The other thing we look for are white blood cells, or so-called inflammatory cells, because it's a clue you have a urinary tract infection. And urinary tract infections are very common in young women who are sexually active. They get urinary tract infections all the time. And so the urinary tract infection can be diagnosed by looking for white blood cells in the urine. It presents, a urinary tract infection typically presents with burning, where someone will pee and they go, oh, it burns. When you hear that, your first thought is, oh, you have a urinary tract infection. May not be, but that's the most common cause. And we look under the microscope for white blood cells. These cells are trying to attack the bacteria. That's why they're there. They're trying to kill the bacteria that are causing the infection. So they're a good thing, these cells, but they're a clue that there's bacteria in the urine. Sometimes we look under the microscope and we can actually see the bacteria. Here's urine with bacteria in it. Now, we want to put the patient on an antibiotic to kill the bacteria. So the question is, what antibiotic? And that's true of any infection, whether it's urine, whether it's an infection anywhere in the body. We always want to know what bacteria is causing it, because we need to determine which antibiotic to give, because we don't want to give antibiotics that don't kill that particular bacteria. We want to give antibiotics that the bacteria is sensitive to. So how do we find that out? Well, what we do is we take a sample, in this case urine, and we put it on this plate. It's called an agar plate, and it has a lot of nice nutrients in it that bacteria love. And if there's bacteria, the plate normally looks like this, clear. But if there's bacteria growing, you get these little colonies. these colonies are made of, one bacteria was here, but he split into two, and then he split into two again and again and again and again, thousands of times, and it makes this colony that you can see. So we get these colonies from some unknown bacteria, and then what a typical plate has also on it, which is not shown here, are little circles of different antibiotics. And so if the organism is sensitive to the antibiotic, there'll be a clear zone. So imagine over here where there's a ton of bacteria growing. Imagine an antibiotic here, here, and here, where the antibiotic that it's sensitive to, there's no bacteria growing. There'll be a clear zone, and that's how we can tell which antibiotic to use. Prior to getting this result, because this takes 2 or 3 days. When the patient came into your office, they're complaining of urine that's burning. You want to give them something that day. Well, you don't get this back for 72 hours. It takes time for these bacteria to grow. You just guess at what the organism is, and you guess at what bacteria to give them based on population statistics. We know typically what organisms cause a urinary tract infection, and we know in general what their bacterial or their antibiotic sensitivities are. So we take a guess. If the patient tells you the next day the burning went away, your guess was right. If they still have burning, then you still have a problem. You may change it again and take another guess, or you just wait till the result comes back and then you know definitively what to do. And that's it. Here we have 2 happy kidneys, healthy, happy kidneys. So the bottom line is, make sure you check your creatinine at least once every couple of years. Know that it's around 1 and not changing. If it is changing, you need to check it out, and check it out while it's still in the 1s before it gets to 2 or 3, because the higher it gets, the harder it is to prevent the inevitable decline of kidney function with time. That's another phenomenon that we still don't completely understand. Why, when you get a kidney insult and the insult has gone away, does the kidney continually decline? Not in all patients, but oftentimes it does. It just keeps getting worse and worse and worse, even though the original problem is not there anymore. So our goal all the time, and the most common patient we get in the clinic, are patients with what we call CKD, which means some abnormality in function. And our goal all the time is to follow them closely and prevent that function from getting worse and worse. That's by far the most common type of patient we see in nephrology clinics now. Okay, I think I'll stop there, and I'd be glad to unmute everyone and if anyone has any questions.